Very good morning to all of you. So real quickly, just to get the disclosure of my way, a few ground supports and a couple of things, none of them which are related to this talk. So the first thing, you have to understand or realize is peripheral arterial disease is one of the most malignant form of atherosclerosis there is. What do I mean by that? If you have peripheral arterial disease, estimates vary from anywhere from 70, 80%, 60% to 80% of them are going to have atherosclerosis in other territories. So this is the first thing. This is the most malignant form of atherosclerosis there is because your outcomes are worse than, say, somebody with just coronary artery disease or stroke. Your outcomes, long-term outcomes, are worse than many of the cancers. And this is something that you have to highlight to your patient because ultimately, they have to understand that this is a big deal as far as the diagnosis goes, as far, from their long-term perspective. The second thing you have to understand is there are two major goals in treating your patient with the peripheral arterial disease. One is taking care of the leg, which is where, from vascular surgery, you'll come in most often. They're coming to you with symptoms to try to take care of them. But remember, most people with peripheral arterial disease don't die from an acute leg attack. They die from an acute heart attack or a stroke. Okay, so taking care of that atherosclerosis aspect of it, it becomes key in your own performance metrics, and these are the things that are being proposed as methods to judging how we're performing as physicians in these settings. So if you look at it, as we talked about, there are two things to consider: the limb outcomes and the cardiovascular morbidity and mortality. If you look at the limb outcomes, it's obviously claudication, improving claudication, and then prevention of progression to critical limb ischemia and amputation. Those are your two goals that you're looking at. Now, as far as the cardiovascular morbidity and mortality goes, it's clearly decreasing it, and we're going to go over both of these. And I'm only going to talk to you about medical management, clearly because I'm not a vascular surgeon and you don't want to hear me talk about limb outcomes as far as that goes. So if you look at what options you have available, if you look at your limb outcomes itself go, exercise becomes a cornerstone. We'll talk about what a regular exercise program should look and the pros and cons of that. Smoking cessation is front and center here too. And finally, there are some pharmacological therapies that are available to help your claudication. We'll talk about what things to look out for when you prescribe those. And as far as prevention of ischemic symptoms go, we'll again talk about the risk factors and what the evidence is specifically with PAD. And these are things that you routinely do for somebody with established cardiovascular disease, but we'll talk about specifically with PAD. At least these are things that you should remember that you give in your recommendations to the primary care provider or the cardiologist or whoever referred your patient to you, so that they are actually taking care of that, because ultimately, for your patient's outcomes to be good, both of these have to be taken care of. So first, the guidelines have been a few guidelines. One was the 2005 and then the 2011 update, and we're using them for this. As you know, class 1 has the strongest recommendation, and class 3 is a contraindication, or you don't use that. Supervised exercise rehabilitation, okay, the key word here is supervised, is one of the key things as far as improving claudication itself goes. One of your best strategies in a person with claudication is actually the supervised exercise program. So a program of supervised exercise training is recommended as an initial treatment modality for patients with intermittent claudication. Now, we're not talking about an acute limb ischemia, we're not talking about a critical limb ischemia, but these are just your regular patients coming in with claudication. A supervised exercise program is the front and center of what you would start with. So typically, they are 30 to 45 minutes, about 3 sessions per week for a minimum of 12 weeks, and that's what you're looking for in a supervised program. Now, unsupervised exercise program, because you find that most insurance companies don't cover these supervised exercise programs. If you don't have this, we always tell our patients to do the unsupervised exercise at home, but just be aware that it's not been well established that this actually has a major benefit. You could hypothesize several reasons. Maybe the patients are not compliant at home. Maybe they don't know how to do it. Maybe they don't know how to push themselves. Maybe they don't have the ability to do it as far as that goes. But overall, when you look at studies, for some reason, clearly, time and again, only a supervised exercise program seems to work. So if you have an ability to do a supervised exercise program, that would be what is recommended. If not, would you tell your patients not to walk? Absolutely not. You would tell them and encourage them to do it. But just beware or understand that as far as the guidelines go and as far as the evidence goes, it's a supervised exercise program that seems to help. Now, here are studies that have shown that exercise training versus control, a meta-analysis of 21 studies, and you can see the change or the percent change in walking time. Pretty significantly impressive as far as what you're able to achieve in persons who are going through claudication. They in fact did a study called the CLEVER study, where they randomized individuals to a supervised exercise program just medical management, or revascularization with stenting and so on. So here they screened quite a few, randomized 119, 22 to optimal care, medical care, 43 to supervised exercise program, and 46 to stenting. And what they found was, over the course of the time, that it was actually the people who had the supervised exercise program who had the largest gains in their walking time, and then stenting came second, and optimal medical therapy was only 3. Just shows you the power of a supervised exercise program and exercise in the setting of claudication. If it's better than stenting those individuals, you can see it's not only the opening of the vessel itself, but ultimately claudication is a mixture of a lot of other things, as you know. So how would a supervised exercise program look? It's again 3 to 5 sessions per week, 35 to 50 minutes. Typically, you walk on a treadmill or a track. You're doing it for 12 weeks and to up to 6 months. Okay. Now, a typical thing would look something like this. You have a warm-up period, and then you exercise, and then you rest. Now, when do you ask them to stop? Typically, you achieve your claudication time, and once you've achieved your claudication time, you push yourself a little bit more, then stop for the rest. Once your pain is gone and subsided, then you start with the exercise and go on and so on. So you can see the pattern of exercise, rest, and final cool down goes. As far as medications to improve claudication, there are 2 FDA-approved drugs. One is pentoxifylline, and the other is cilostazol. That is, as you can see below there, there's inadequate evidence of clinical efficacy or a therapeutic role for L-arginine and all the other ones that you see there, although they've all been studied or variably used. Pentoxifylline has been there, since probably before you were born. 400 milligrams 3 times a day is the dose. It's considered to be a medication that has properties that, it's hemorrhagical. It changes the RBC profile, so it's thought to improve claudication with that, and has a little vasodilation itself. Cilostazol is the more important drug, if you would, for using for claudication, and it's a phosphodiesterase inhibitor. It's been there since 99 right now. The dose is 100 milligrams twice a day. It also has been shown to inhibit platelet aggregation and can increase your HDL and lower your triglycerides. Now, the important thing, here are the studies that have looked at them, and this is one study that compared cilostazol versus pentoxifylline, and you can see pentoxifylline barely did better than placebo, while cilostazol, clearly improved your walking time a lot better. So to me, for all practical purposes, cilostazol should be a first-line drug if you're using a medication for claudication. What's the contraindication? Any kind of heart failure, any reduced EF, any symptoms of that, because phosphodiesterase inhibitors by themselves can retain fluid, and you can actually precipitate heart failure in these individuals. So that is the major contraindication for use of cilostazol. So if CHF of any severity, any EF, less than 50%, I would not, use it. The guidelines call it a 1A for improving claudication, while for pentoxifylline it's a 2B. And the other things, as we talked about, L-arginine, carnitine, ginkgo biloba, all of these things are class 2B, and the other things that are class 3, including vitamin E, chelation, and all of that. But there is a lot of studies and efforts in, for example, an angina, cardiac angina for chelation and all of that. And these are things that you may hear over the course of the next 20 years. But as it stands now, these are front and center. So essentially for claudication itself, remember walking is the key thing. That's the best evidence there. After that, you can try cilostazol or pentoxifylline. Cilostazol clearly does a lot better. Cilostazol, just watch for heart failure. Now, smoking cessation therapy is kind of a bridge between both for claudication as well as for improving your cardiovascular outcomes. So obviously you have to encourage them to quit smoking. Now, the 2011 recommendations went on even more stronger. And essentially what they're saying here is that we should not, as physicians and clinicians and practitioners, not only say, smoking cessation is important to your patient and be done, but actually document and also go through strategies of how you're doing that. There are actually some very nice algorithms they try to ask you to follow, which is assess where your patient is ready to quit, then encourage them to quit, discuss the side effects with them again and again at every visit. People who have quit, congratulate them and keep them encouraged as far as that goes. Because as you know, one of the key things in prevention of both your critical limb ischemia or cardiovascular disease is smoking cessation. So as a clinician taking care of these individuals, this should be emphasized multiple times in every visit and every opportunity you have. And in fact, it's a performance metric. If you are or not doing these things, it's a performance metric about how you're doing there. Now, if you look at this study, which looked at effect of smoking cessation on survival. These were 133 patients observed after a bypass graft or a lumbar sympathectomy. And you can see this is the natural survival of the population. This was done in Australia. You can see people who quit smoking and people who continued smoking. Clearly the ones who continued smoking did the worst. There are several studies showing that it's bad. This is just one of them showing the importance of that. The next thing when you're looking at medical management of patients with peripheral arterial disease is preventing the cardiovascular outcomes as we talked about. Statin therapy can also help you with claudication time, and we'll look at that, but also clearly is one of the best ways to decrease your cardiovascular morbidity. Now, until 2013, what used to be the guideline recommendation was an LDL cholesterol goal of less than 100 for anybody with established atherosclerosis of any form, PAD included, and less than 70 in individuals who are at higher risk, such as those with PAD. Now, 2013, there were a new set of guidelines that came about for lipid management. And here, what they asked you to do is one thing. Ignore what the LDL cholesterol is, okay? Concentrate more on the intensity of statin therapy, which makes it easier for you because all you're doing is if your patient is able to tolerate it, if your patient has PAD or any form of atherosclerosis, which is defined as greater than 50% stenosis in any artery, okay, you put them on high intensity statin. And what is high intensity statin? Something that can decrease your cholesterol by 50%. Currently in the market, there are two that are available from statins. There's rosuvastatin 20 to 40 milligrams or atorvastatin 40 to 80 milligrams. So in a way, you do not have to worry about what the baseline LDL cholesterol is. You just start them on a high intensity statin therapy if they're able to tolerate. Why? There have been studies that have looked at high intensity versus low intensity statin and clearly showed benefits with the high intensity statin therapy. One of the questions you may be faced with is, my patient's LDL cholesterol is 110. Will I lower his cholesterol too much if I start him on, say, 80 of atorvastatin? Remember, the best statins give you a 50% reduction. So if you start somebody on LDL cholesterol of 110, you're only going to get them to 55. Okay. Now, we have studies now going with people who have achieved LDL cholesterol less than 40, and people seem to tolerate it fine. There's not a huge, side effect or any problem with tolerating that. So for you, in a way, don't even look at the cholesterol value. Starting them on high-intensity statin is a guideline recommendation. It's an easy thing to do, and you can get your patient, make sure they're on that, and start with that. There are newer updates to these guidelines where they've added a second target of LDL less than 70, in which case you would add ezetimibe on top of this medication. But a simple way for you to start where you've done a lot of good work is starting a statin at a high-intensity statin therapy. Now, here's the data showing in PAD. You can see, like in any other group, PAD statin was favored as far as decreasing cardiovascular event in the heart protection study. And here's a claudication time. Now, this is atorvastatin 1 study, which looked at 10 milligrams, 80 milligrams as placebo, and mean change in your peak walking time. You'll see that the 10 milligram for some reason did better early on, but the 80 milligram catches up later on. Part of this might be also, remember, one of the side effects of statin is muscle pain. So you might be picking up a little early where, and the higher the dose, the more the chance of the side effect. So that is the one thing that you have to keep in the back of your mind when you're doing this. But overall, you can see both of the groups increase your, improve your claudication time or distance to claudication. So it also helps you from that regard. As far as antihypertensive therapy goes, your goal used to be 140 over 90 for non-diabetics and 130 over 80 for diabetics. This has changed a little bit. I'm going to go over that briefly for you. The other thing that was thought is beta blockers are contraindicated in PAD. That's no longer the case. There have been several studies that have looked at beta blockers in PAD, and it's okay and safe to use them. Now, typically when you're going to have more claudication with a blood pressure agent is if it drops the blood pressure by 20 millimeters or more. Most medications drop your blood pressure by about 10 millimeters. So starting them and getting them to go should be reasonable and should be well tolerated by your patient. ACE inhibitors, it's useful to decrease cardiovascular endpoints. Typically, we use them in people with established, heart disease with a lower EF. That's where the strongest evidence is. But otherwise, it's also a class 2A and 2B indication for just decreasing vascular events itself go. So overall, PAD per se, you don't have to choose a medication that's directed towards it. What you would do is you would choose for other indications. For example, if you have reduced EF, you'd go to ACE inhibitors, CKD ACE inhibitors, heart failure ACE inhibitors, or beta blockers, or the combination of the two. So you would just use it based on that. And most of this should be taken care of by a primary care provider for that purpose. So as we talked about, beta blockers are not contraindicated. So the new guidelines came about again in 2013-14, where one thing they did was for ages greater than 60, they relaxed the systolic blood pressure and diastolic blood pressure goals. Why? Because the benefit you get from 140 or 130 or so compared to the potential risk of the lower blood pressure, especially in older individuals, kind of weighed off each other. Because you were seeing a lot more people with little dizziness and things like that that were getting to that. As a result of it, you can tolerate a little bit of a lower blood pressure reading as far as that goes. But this is, again, a changing field because newer studies have shown benefit also with lowering the blood pressure further. Now, as far as diabetes care goes, proper foot care, you know about it. There's no specific hemoglobin A1C goal. Less than 7 is great. 7 to 9 is reasonable. This is the data showing the improvement of it. As far as antiplatelet, I'm rushing through this because I'm getting out of time. As far as antiplatelet agents go, again, it's for prevention of heart disease. Aspirin is a good start. If you can't tolerate aspirin, clopidogrel is a good alternative. There have been some studies that have looked at combinations suggesting maybe a little benefit, but there is a problem of slightly higher risk of bleeding. So aspirin or clopidogrel is what is recommended at this point of time. And you can see in PAD, clopidogrel seem to be favored, but overall from a cardiovascular risk reduction, they are kind of wash off, so either one of them should be in your patient. But just remember, despite all of what we talk about, it being the most malignant form of atherosclerosis and all that, it's consistently undertreated. There have been several studies that have looked at PAD populations, and here's one of them, the Partners Registry, where you see that lipid-lowering therapy in patients with either prior or new diagnosis of PAD is almost just like in controls. Okay? Part of the reason is who's taking care of the patient. Internist refers to vascular surgeon, thinks the vascular surgeon is taking care of the PAD. The vascular surgeon thinks, listen, I'm dealing with the claudication, not dealing with the risk factor modification. So this is why a correspondence between the two is going to be very important in taking care of them. And these are going to be PAD performance metrics where they look at that. With that, I'll stop, and thank you very much.
All right. Thank you.